Resuscitation part 1. So it will be discussed in two parts, part 1 and part 2. Part 1. First thing I want you to be aware of how to do an back mask ventilation. It's an ambu bag, you can use it, or any back mask ventilation when you are doing to a person. What are you looking for? You're looking for the chest rise. Whenever you push the air inside, is the chest rising or not? So next question is, when do you use an back mask ventilation? We use an back mask ventilation when the person is doesn't have any respiratory efforts, or the respiratory efforts are very poor respiratory efforts they are having. That means they cannot suck the air inside. The muscles are not contracting, or they are just exhausted. At that point of time, you need to push the air inside. Okay, to push the air inside, you push it with certain amount of pressure using a back mask ventilation. When you're pushing the air inside, the lungs expand. When the lungs expand, you see the chest raise. Once you see the chest raise, you are sure that yes, the air has entered in. What if you do not notice the chest raise? If you do not notice the chest raise, you go and see that whether the mask is making a good seal or not. Around the mouth, if this is the lips what you are having, around the mouth you have placed the mask. Is it making a good seal or not? Is there any air leak is present or not? If there isn't any air leak is present, you need to hold it properly. Basically, the technique might not be good. No, air leak is not there, but still you feel that there might not be perfectly fitting mask. For example, it is not sitting over the nose properly, or it is going over the eyes here, or it is going beyond the chin. In those circumstances, you might have to change the mask size according to the patient size. If mask seal is good, the mask size is fine, seal is good, still there is no chest stress. At that point of time, you need to do airway maneuvers. Airway maneuvers, for example, it might be a head tilt maneuver, a chin lift maneuver, or a jaw thrust. Usually we do a head tilt chin lift together, or we do a jaw thrust. Jaw thrust is preferred in the trauma cases. We do not do an head tilt chin lift in a trauma case because there are chances that there might be a C-spine injury and you might worsen the C-spine injury. You try the simple airway techniques by doing a jaw thrust, for example. Still, if there is no chest raises present, that's when you use a two-person bag mask technique. Two persons, that means one person is holding the mask, another person is ventilating using it might be a self-inflated bag, like in the ambu, it might be, or any other bag. If that is also not working, that's when you insert an advanced airway. Advanced airway can be an endotracheal tube, or it can be a supraglottic airway devices like an iGel. If that is also not working, that's when you go for a front of neck access. Emergency airway, a front of neck access is nothing but surgical airway, what we are talking about. A cricothyroidotomy, surgical cricothyroidotomy, what you are talking about. So we go in this sequential manner whenever we do not see and chest raise because of back mask ventilation. So now we are starting the registration proper. The entire class is based on Registration Council UK, except a trauma one where they do not have any guidelines. So I'll be letting you know if I am debating from the Registration Council of UK. So you need to stick to the Registration Council of UK itself, not USA. ACLS belongs to USA. There are few changes. So disregard what US has been taught. This is an UK exam. So you need to stick to the Registration Council of UK. First thing is basic life support. Basic life support in a community setting. That means out of hospital, what you do. Out of hospital, when there is unresponsive and not breathing normally, okay, then you immediately ask for help. Either you call for the ambulance by dialing 999, or if there is someone else, you shout for the help and ask them to call the ambulance and get an AED if possible as soon as possible. AED usually it will be available in the community centers. If it is not available, then you continue with the chest. If it is available, you get it as soon as possible and connect it. This is another person who is doing. It's not you. You're sending for another person. You're calling for help and you're sending another person. What you will be doing is you will be immediately starting on the chest compression. The thing what is missing here is checking for the signs of life. In community, who are the ones? We may not be the doctors. It might be a teacher, for example, in a school setting, or it might be an security guard, or it might be an police constable who will be doing this. They may not be skilled enough to check for the signs of life. For example, checking for a carotid pulse, you need to have certain amount of skill. That's why what they say is if the person is unresponsive or not breathing properly, or combination of both, at that point of time, it is recommended that you directly start on the chest compression. 30 chest compression with 2 rescue breaths. So you're continuing at the ratio of 30:2 till the AED is available. AED stands for automated external defibrillator. Once an AED is available, you connect the AED and you follow the instructions what is given in the AED. It is an automated one. So it recognizes the rhythm. It says whether to continue the CPR or whether to shock the patient. If it's supposed to be shocked, it shocks on its own. It's an automated external defibrillator which are present in the communities. What about in a hospital setup? So in a hospital setup for an adult, what we do? So you come across and collapse or a very sick patient. It might be while you're doing an ward rounds, or it might be in the resuscitation bay, or it might be in the triage, anywhere in the hospital settings. First thing what you do is you shout for the help. You shout for the help and assess the patient. What you are assessing? You are assessing for the signs of life. So first you are asking for the help, then you are doing an assessment. In assessment, you're checking for the signs of life. Two important things what you're checking for: is the patient conscious? Okay, he's collapsed. He might be still conscious. You might be able to wake him up. He might be just drowsy or he might be just sleeping. So just try to wake him up, see whether the breathing is normal or not. If the ALS provider is experienced, most of us are experienced because we are emergency physicians. It is expected of you to check for the carotid pulse. So once you find whether the patient is waking up or not, if the patient doesn't wake up, you immediately check for the carotid pulse. You are not able to feel the carotid pulse, or if you are in any doubt, you call it as a cardiac arrest. If you're not put out a call already, you put out a call here and collect the equipments, which includes the manual defibrillator, all the emergency drugs, basically resuscitation trolley. You want to get it. Get the resuscitation trolley immediately and start with high quality CPR in the ratio of 30:2. What you're starting the high quality CPR. Connect the defibrillator. Once the defibrillator is connected, then you follow the advanced life support. If the team has come over already, then you can hand over the case. What if the patient is collapsed, but the patient is, you are able to wake him up or her, or the carotid pulse is felt? If the carotid pulse is felt, or if you're able to wake the patient up, at that point of time, you're doing an ABCDE assessment. So is airway fine, breathing is fine, circulation is fine, deformities, anything are present? What about on exposure? So you're going in this format and you are assessing the patient. As we are learning about resuscitation, so we are sticking to the cardiac arrest algorithm as of now. Before you go and see for an collapsed or sick patient, it is always important that you maintain and personal safety. Okay, maintain personal safety is utmost important. There might be a person with a radiation exposure and collapsed in the emergency department. So you cannot you should wear an hazmat or PPE, you should wear an personal protective equipments before you touch the patient. It might be a COVID patient who has collapsed. You might catch the COVID. So you need to wear and personal protective equipments before you even go near the patient. That is what is very important. See for the scene safety, look out for your personal safety, then only assess the patient. In general, what do you need to remember for the exam purpose? Maintain personal safety is the first thing. Then, if the patient is unresponsive, yes, the patient is unresponsive, immediately call for the help. After you call for the help, see whether the patient responds for an painful stimulus. No, if the patient doesn't respond at that point of time, immediately check for the carotid pulse and breathing. If present, you're doing an ABCD assessment. If absent, you're starting the CPR at 30:2 ratio and connect the AED in the outside hospital setting. Most of the time, this algorithm, what I'm talking about, is the in-hospital setting. So you're not connecting the AED. Most of the time, the preferred one is a manual defibrillator. So manual defibrillator, you are connecting. Once you're connected the manual defibrillator, then depends on the rhythm what is present, you will be going ahead. So when you are doing NCPR, certain things you need to be aware of. At what rate you are doing in an adult? You're doing an adult at a rate of 30 compressions. After 30 compressions, you are giving 2 rescue breaths. At what rate? Means at what speed you need to do it. You need to do it at a rate of around 100 to 20 chest compressions per minute you need to do it. At what depth? Approximately 5 centimeters is the depth. Not more than 6 centimeters is the recommendation for an adult patient. Where you're supposed to place the hand? The hand supposed to be placed at the lower half of the sternum. Lower half of the sternum, it is the preferred place where you need to place it. So after giving 30 compressions, you give 2 rescue breaths. When you're giving it 2 rescue breaths, it is recommended that you do simple airway techniques when you're delivering the rescue breaths. It might be delivered from mouth to mouth rescue breaths, or it in an, most of the time outside hospital setting, you might not be available back mask ventilation. You do and mouth to mouth breaths you will be giving. Head tilt chin lift maneuver is recommended at that point of time if it's non-traumatic case. If it's traumatic, jaw lift technique is recommended when you're giving rescue breaths. Ambu bag is available. Use ambu bag to give the rescue breaths. At the same point of time, make sure you're using simple airway techniques when you're delivering the rescue breaths. When you're giving the rescue breaths, you give it over and seconds time. Okay, at the same point of time, have a closer look at the chest rise. Is the chest rise present or not? Manual defibrillator is always preferred in an hospital setting. Whenever possible, use manual defibrillator. If it is not immediately available, you can use an AED. When do you check for the rhythm? What is the heart rhythm present on a defibrillator? You check it immediately after connecting the defibrillator. So immediately after connecting the defibrillator, it might be only 1 minute since you started the CPR, or it might be only 30 seconds after you started CPR, or it might be 3 minutes after you started the CPR. Doesn't matter. Once you connect the defibrillator, stop the chest compressions and immediately assess for the rhythm. So rhythm might be anything. You intervene accordingly. You enter into the adult ALS algorithm, which we'll be learning in the next slide. After that, after first rhythm check what you have done, soon after connecting the defibrillator, you checked once. After that, every 2 minutes, you will be checking for the rhythm. So rhythm is checked every 2 minutes. If you're skilled enough to place an supraglottic airway device, or if you're skilled enough to place an endotracheal tube without stopping chest compressions, then go ahead and do it. If you're trained and if you're skilled enough, then do go ahead and place it. The last point is the position. The position is also very important. How do you position yourself? You know that you are placing your hand at the lower half of the sternum, what you are placing it, but your elbow should be locked and your shoulder should be right above. That means it should be straight and it should be right above the chest of the patient, what is there, on whom you are performing the chest compressions. That is very important. So keep your arms straight, position shoulders vertically over the patient. That is right above the patient. It is important. And interlace, if you require, interlace it, and your heel of the palm should be over the sternum, not the entire palm, only the heel. With the heel, you should be pressing downwards, and you should allow the chest to completely recoil back. Okay, you pressed 5 centimeters, then you need to completely recoil it back. You should allow the chest to expand. Okay, if you're just pressing and you're going deeper, for example, you press 5 centimeters, you recoil back only 3 centimeters. This will not be helpful. This will prevent the venous return. So this shouldn't be done. So you should allow the chest to recoil. Advanced life support. Advanced life support, again, it starts with BLS itself. So BLS itself, so you maintain the personalized patient is not responding. You called for the help immediately. Then what you'll be doing, you're checking for the signs of life. Signs of life are not present. Then you started the CPR. Once you started the CPR, immediately one of the persons or one of the help person will be attaching the monitor and defibrillator. Once it's attached, doesn't matter if it is 2 minutes or not, doesn't matter if it is only 30 seconds, you immediately assess the rhythm. The rhythm can be a shockable rhythm or can be a non-shockable rhythm. Okay, that you need to assess. Let us see the rhythms, which we have already learned. This is nothing but VF, ventricular fibrillation, what you're having. These are nothing but VT, ventricular tachycardia. This is a polymorphic ventricular tachycardia. This is a monomorphic ventricular tachycardia. Whenever you are assessing for an ventricular tachycardia, also check for the pulse. It should be an pulseless ventricular tachycardia. If there is a pulse, that means you have a return of spontaneous circulation. If there is no pulse, then we call it as an pulseless ventricular tachycardia. The ventricular fibrillation and pulseless ventricular tachycardia are two rhythms where you can shock the patient. All right. Whenever this is present, this is almost a straight line. This is known as asystole. Or whenever any other rhythm is present other than pulseless ventricular tachycardia and VF, any other rhythm, for example, pulseless, it might be an atrial fibrillation, or it might be an SVT, or it might be any other rhythm for that matter. All this becomes pulseless electrical activity. Why do we call it as in pulseless? There is no pulse which is present. When you palpate for the carotid pulse, that's the central pulse. There is no pulse what you can feel for. But the electrical activity is seen. You can see there is some electrical activity which is happening in the heart. So it is a pulseless electrical activity. Only electrical activity is present there, but there is no mechanical compression which is happening, what you need to be aware there. So if it is a shockable rhythm, immediately give the first shock and continue with the CPR. After giving the shock, usually the people what they do is check for the rhythm. check for the pulse. No, you're not doing it. Once you give the shock, you immediately resume the CPR. Do not check it. You check for the rhythm or you check for the rhythm only after 2 minutes. Do not check in between. If it is a non-shockable rhythm is a pulseless electrical activity or a asystole is present, then you immediately resume CPR, continue the CPR for 2 minutes. In the meanwhile, you will be giving adrenaline. As soon as possible, you need to deliver the adrenaline. What is the adrenaline dose supposed to be given? Adrenaline, what you are giving is 1 mg IV. In what dilution? 1 is to 10,000 dilution. Again, the people think it is 1 is to 1,000 dilution, which is wrong. It is 1 is to 10,000 dilution. So 1 ampule contains how much? 1 ampule contains 1 ml, which has 1 is to 10, sorry, 1 is to 1,000 dilution. It will be 1 ml, it will be. So it is 1 mg what is present in 1 ampere. So you need to mix it with 9 ml of normal saline to make it as an 10 ml solution, where it becomes 1 is to 10,000 dilution. This 10 ml solution is supposed to be given in the IV as a bolus in the patients with a cardiac arrest. Amiodarone. When do you give amiodarone? After the third shock. Okay, after the third after the third shock, you are giving amiodarone of 300 mg. What you're giving. Then next dose of amiodarone is given after the fifth shock, and the dose here is half. First you are given 300, next you are giving 150 mg IV. Why we are giving amiodarone? Amiodarone makes the patient sensitive to the shock. The chances of getting an ROSC, that means converting an VF and VT after a shock, are high if you give an amiodarone. That's why we are giving an amiodarone. And you can, if the amiodarone is not available, then you can use lidocaine also. Lidocaine is 1 mg per kg what we use it. Approximately we use it and 50 mg in an adult patient. Lidocaine also can be used as a replacement for amiodarone, but preferred one is always amiodarone. If amiodarone is not available, then use the lidocaine instead of that. Another thing that which I missed to tell here, after the third shock, I said you need to give an adrenaline, amiodarone. Along with the amiodarone, you need to start on the adrenaline also. And adrenaline is repeated after every 3 to 5 minutes. Another confusion usually comes is you have assessed the rhythm. It is a non-shockable rhythm. You have continued the CPR and it is for and given the first dose of adrenaline. Then you assess the rhythm after 2 minutes. When you assess the rhythm after 2 minutes, it is a shockable rhythm. You shock the patient. Do we give another dose of adrenaline after 3 to 5 minutes if it remains in the shockable rhythm itself? Yes. Once you start giving adrenaline, you continue giving every 3 to 5 minutes. You're not stopping in between because it is a shockable rhythm. Same thing holds good here. After third shock, you're giving amiodarone as well as adrenaline. Once you start the adrenaline, you are giving every 3 to 5 minutes. You are not stopping in between. Every 3 to 5 minutes, you are giving adrenaline. The best way to remember when to give an adrenaline is alternative shocks. Alternative chest compressions. That means 2 minutes. First, you are given adrenaline here. 2 minutes are up. Then again, you start CPR. 2 minutes are up. Before you start the CPR or CPR is just started, then you give one more dose. So alternate cycles, you will be giving adrenaline dose. That is an easier way to remember, but you have to remember it is 3 to 5 minutes from exam point of view. That is nothing but alternative cycles what we'll be giving. When to change the person who is basically doing a chest compression? It is recommended that every cycle you change the person who is giving chest compressions, mainly because giving a chest compression for whole 2 minutes is quite tiresome. It is recommended that you change the person who is doing a chest compression after every 2 minutes. Few more things what you need to be aware of. You're trained and you're qualified enough to place a supraglottic airway device or an endotracheal tube. Then what do you do? Then you do not stop after 30 chest compression to give to ventilation. You give and continuous ventilations. So you're not stopping continuous ventilation. That means 200 compressions over 2 minutes what you are giving here. You're not stopping in between to give the ventilation. So ventilation is given at what rate at this point of time? If you have an advanced airway like an supraglottic airway device or an endotracheal tube, what you'll be doing ventilation here is you're giving it every 5 to 6 seconds. In another way to remember here is we are giving around 10 to 12 breaths per minute what you're giving. In a practical purpose, it is important that it is 5 to 6 seconds because you will be counting 1, 2, 3, 4, 5. So it is 5 seconds. Let me give a ventilation breath. Chest compressions will be continuous. You're not stopping the chest compression to give the ventilation. If the personnel needs to be changed in between, for example, you are assessing the rhythm and you are stopped, how long? It is recommended that 5 seconds, maximum 10 seconds, but it is recommended that keep it as minimum as possible, as less as possible, like 5 seconds. You are placed in supraglottic airway device, but you are suspecting there might be an gas leak. That means air leak might be present. If air leak is present, then to give the ventilation, stop it. After 30 chest compression, to give 2 ventilated breaths, stop the chest compressions because there is a air leak present. Optimal ventilation will not happen if you do an continuous ventilation. This doesn't hold good for an endotracheal tube because once you place an endotracheal tube, usually we confirm it by placing an EtCO2. It helps if there is a rapid increase in EtCO2, that is a waveform capnography, end tidal carbon dioxide I'm talking about as an EtCO2, there is a sudden rise in EtCO2 that might be indicative of a return of spontaneous circulation. That shouldn't be the only indication for you to stop the resuscitation, stop the chest compression. Okay, you should look for other signs of life. For example, you are doing an recitation, suddenly you saw there is an, this is the, what you are having EtCO2, and suddenly you see an spike like this in EtCO2 monitoring. If you're seeing a sudden spike like this in EtCO2 monitoring, what you're supposed to do? For a time being, for a fraction of a minute or few seconds, like 5 seconds, stop the CPR and look for central pulse. If central pulse is not there, continue CPR. What do they mean by, however, chest compression should not be interrupted based on this sign alone? That means do not stop it completely. Okay, you can stop for 5 seconds and check it, but do not stop it completely, what they are telling here. That means do not think that it is a ROSC, not being interrupted based on this sign alone. If there is something else also, for example, patients, there is a flickering movements are present, then you can stop. Or there is a central pulse is present, then you can stop. When do we use a mechanical chest compression? Mechanical chest compression is used when you do not have enough personals or you're getting tired. You're planning to restrain this patient or do chest compressions for a longer time, like 2 hours, because you're planning to get an angiography or angioplasty done for this with ongoing, or you're done a thrombolysis where minimum of 2 hours is recommended continuous chest compressions. In those circumstances, it is recommended that you use a mechanical chest compressions if you do not have enough manpower. If you have a manpower, it's always recommended manual chest compressions are better than the mechanical chest compressions. When we are doing the recitation, when you are following the ALS algorithm, in between 2 minutes, when you are waiting for the rhythm check, someone is doing a chest compression. As a team leader, what are you trying to do? As a team leader, you are assessing for the 4 H's and 4 T's. These are known as reversible causes. If you can find one of these causes and intervene immediately, there are chances that you can get a spontaneous return of circulation. ROS can be achieved. You are looking for this 4 H's and 4 T's. In 4 H's, first one is hypoxia. Okay, reduced oxygen level, hypoxia, hypovolemia, hypokalemia, or metabolic abnormalities. It includes low potassium levels, all those other electrolytes I'm talking about, like in calcium, magnesium, everything includes it. Hypothermia, core body temperature we are talking about. Cardiac tamponade, toxins, thrombus, it can be coronary thrombus or a pulmonary thrombus, and tension pneumothorax. Let us see each one of these 4 H's and 4 T's. First one is hypoxia. How do you identify an hypoxia? Get an ABG done. Okay, get an arterial gas analysis done. If the PaO2 values are less than 10 kilopascals, you need to expect that it might be hypoxia related. So, you, as any resuscitation, you will be doing back mask ventilation with 100% oxygen. But additionally, try to place in supraglottic airway device and tracheal intubation if you are strongly suspecting it is the hypoxia which has caused the cardiac arrest. For example, drowning patients, it is highly recommended that you place an endotracheal tube in those patients. Hypovolemia, blood loss. Blood loss can be in any form. It might be because of the trauma you have in hemorrhage and there is a blood loss. It might be because of burns, there is a subcutaneous blood loss. It might be because of sepsis, there is a third spacing of the blood loss. It might be anaphylaxis where there is a distributive shock which is present. Okay. That is nothing but fluid lost into the third place again in anaphylaxis. When you're suspecting this, then you resuscitate with the fluids. Especially if it is an hemorrhagic cause, it is recommended that you give blood, and blood products are recommended at this point of time because blood is lost and you are replacing with the blood. That becomes the best fluid if it is available immediately. Most of the time, it will not be available in the emergency department. You need to get it from the blood bank. It takes time, so you end up giving fluid boluses. Hyperkalemia, metabolic disorders, two main things what we need to aware of. One is the potassium abnormalities, another one is the magnesium. Whenever the magnesium levels are less than 0.65 millimoles per liter, supplement with the magnesium. How much magnesium you need to give it? 2 grams IV. Push it is over 1 or 2 minutes IV. What you're giving, 2 grams of magnesium sulfate is recommended. Potassium values. If the potassium is on the lower side, hypokalemia it is present, then 20 millimoles of IV potassium is given over 10 minutes. Then what you'll do, then you will reassess the patient. That means get another venous blood gas or an arterial blood gas, run it through an analyzer where most of the analyzers will give potassium values and see whether it has come to the normal range. That means it has gone above 3.5. No, it has not gone above 3.5. Then give 10 millimoles IV over 5 to 10 minutes. Okay, so you keep on giving this. First, 20 millimoles IV over 10 minutes. Recheck the potassium values. If they're not spiked up, then again you are giving 10 millimoles. Here, from 20, you are reduced it to 10 millimoles IV over 5 to 10 minutes. If it is a hypothermia, you need to warm it, use active and passive warming both. For example, you need to increase the room temperature. Hard saline infusion, you need to give it. For example, you can do an bladder wash with an hard saline, or you can infuse IV, which is warm. So in that manner, you will increase it. Whenever you are suspecting an hypothermia, it is always recommended that you use an low reading thermometer. It is important. Hyperkalemia. Hyperkalemia is very important. It's one of the most commonest causes for an cardiac arrest in adults. What we do, the first drug what you will be giving, the first priority you should give for the drug is the calcium. Either you can give an calcium chloride or calcium gluconate can be given. Both have same effect. Okay, it's not that one is superior than the another one. If they force you to choose between an calcium chloride and calcium gluconate, it is recommended that you choose an calcium chloride because it is only 10 ml what you are supposed to give it. 10 ml IV, 10% of calcium chloride over 2 to 5 minutes. So you're giving only 10 ml. So it is easier to give 10 ml compared to the 30 ml what you are supposed to give in an calcium gluconate. Both is given over 2 to 5 minutes. Start on insulin dextrose infusion. A short-acting insulin like human actrapid will be added to the 50 ml of 50% dextrose over 15 minutes infusion what you are giving. Sodium bicarbonate. Sodium bicarbonate, you're giving 50 millimoles IV bolus. For example, 50 ml of 8.4% sodium bicarb what you'll be giving. When do you do an dialysis? You do an dialysis when the patient is resistant to hyperkalemia. If the patient is resistant to hyperkalemia, at that point of time, dialysis is recommended. Dialysis cannot be done with an ongoing CPR. It becomes very difficult and dialysis takes hours. It doesn't happen in a minute and you need to place a dialysis catheter. So when is dialysis really preferred? Dialysis is really preferred if the patient is on ECMO. You place the patient on ECMO, then dialysis will be really preferred. I'll be talking about ECMO in coming up slides. Next 40s. First one is the cardiac tamponade. Cardiac tamponade most commonly seen in a traumatic case. Okay, so we'll be studying about traumatic cardiac arrest, but remember cardiac tamponade and tension pneumothorax, these are the two components which we suspect in a trauma. But tension pneumothorax also we suspect in a patients with an asthma or any chronic lung diseases like an COPD, also you're suspecting tension pneumothorax. Cardiac tamponade, it's mainly focused towards an patient who had a trauma, especially a penetrating trauma to the chest, we can suspect. Ultrasound scan becomes very important here to make a diagnosis. Ultrasound scan, whenever you do in a cardiac arrest patient, and if you see fluid around the heart, that is nothing but black color what you're seeing around the heart is suggestive of an cardiac tamponade. This fluid is nothing but pericardial effusion. In a cardiac arrest patient, you need to consider this as an cardiac tamponade. Toxins. How do you do or make out a toxin? For example, opioid can be easily picked up. They'll have pinpoint pupils, so you know it might be an opioid and they might have needle marks. Other things, it depends on the history. Okay, has he taken a drug overdose? Paramedics have told, or any collateral history from the relatives is suggestive of a drug overdose, or a nurse says ended up giving a drug overdose by mistake. I'm not supposed to give it. I've given double dose. In those agents, if there is a reversal agent, Q, for example, opiates has a naloxone, Q naloxone in those circumstances. Thrombus, it can be coronary or pulmonary thrombus. Coronary thrombus. Coronary thrombus, mainly you need to depend on the history. Other than the history, it becomes very difficult. So you mainly have to depend on the history for coronary thrombus. Okay, or a ECG is taken just before the cardiac arrest and it is suggestive of a myocardial infarction. If you're suspecting a coronary thrombus, it is recommended that you do an angiography and angioplasty if possible. with ongoing CPR. Can you do an angiography and angioplasty? Absolutely, yes, you can do it, get it done. No, you do not have the cardiologist available immediately, or the cath lab, some other patient is there, or the cath lab is down, you cannot do it. In those circumstances, you can thrombolize the patient. Next one is the PE. How to find out the patient is having a PE? Getting an echo scan done with ongoing CPR is important here to make out whether this is a PE or not. So focused cardiac ultrasound will be helpful, where you will be seeing for an RA-RV dilatation, or an D sign, what you'll be seeing, what we have learned in the cardiology chapter. Along with it, is the patient is a known case of DVT, or just have a look at the lower limb. One limb is quite swollen compared to the other limb, suggest you of an DVT. If possible, use that same ultrasound probe and you see whether the femoral or the popliteal veins are patent or there is a clot present. That is an indirect evidence of saying that yes, this patient might be having a PE. So we need to have an indirect evidence to thrombolize the patient in NPE. You cannot just suspect a patient having a PE. So either you get an echo scan done and see an RA-RV dilatation, or you see the lower limb and you suspect an DVT, or you do an you do an lower limb scan, the venous Doppler scan, basically to be more precise, and see the femoral vein and the popliteal vein and see whether there is a clot. If present, then you will go ahead and thrombolize. The dosing, what I have mentioned here, is for your knowledge purpose. What I have mentioned here, you need not remember from the exam point of view. All right, one is not superior over the another. Most of the time, tenecteplase is preferred in an cardiac arrest because you can give it in a bolus form. Alteplase needs to be infused over 30 minutes, takes time. If you're planning to give thrombolysis, or you're planning to thrombolize the patient, you're planning to give a thrombolytic agent, always be prepared for a prolonged CPR. As prolonged as 2 hours, you need to give an CPR in a patient. Thrombolytic agent will not act once you push the drug inside. It doesn't act within minutes. It takes hours together. So you need to be prepared to see the results for 2 hours. You need to prepare your team to resuscitate this patient for as lengthy as 2 hours. Tension pneumothorax. Tension pneumothorax, you can auscultate the patient when you're giving rescue breaths and see whether there is an absence of that sounds at one part, or if there is a tracheal deviation to the opposite part. You can percussion see whether it is an hyperresonance which is present. Okay, most of the time, tension pneumothorax is in a trauma case, but it can be seen in any chronic lung disease also. Ultrasound scan, you will be seeing barcode sign. A barcode with any grocery item, you take it, you see the barcode. The same thing here, if you keep it in the horizontal manner, it appears like a barcode. That's why it is known as barcode sign. Preferred one to do in a trauma case is thoracostomy. You can also do a needle decompression if you are not well versed with thoracostomy. When you're doing a needle decompression or a thoracostomy in an adult patient, it is preferred to be doing between the mid-axillary line and the anterior axillary line in the fifth intercostal space. I do understand that I have mentioned here just anterior to the mid-axillary line. This is according to the ATLS 10th edition. So you need to be aware of this. And according to the 11th edition, what they have said is go a little bit more anterior. So they have made it between the anterior axillary line and the mid-axillary line you are placing it. That is according to the 11th edition of the ATLS. Both you need to be aware of. They can test you on 10th or the 11th edition. Child. In child, it is preferred in the mid-clavicular line in the second intercostal space. ECMO, also known as extracorporeal CPR. What is this? This, both the respiration as well as the circulation is supported externally. With the machines, it is supported externally. It is supported. With an extracorporeal CPR, that is ECMO, short form is ECMO. In this patients, what you can do? You can get a dialysis done. You can buy time. The most important thing is you can buy time. You can place the patient on ECMO and get an angiography, angioplasty done. You can get a dialysis done. So you're trying to buy the time here. Ideally, this has to be started within an hour's time of the cardiac arrest, and it is preferred to be done in young patients rather than in elderly patients or any patient who is having a refractory arrhythmia. Refractory arrhythmia is it's a VT, pulseless VT or an VF. You're giving shock. They're not responding to the shocks. Those are known as refractory arrhythmias. In those patients, it is recommended that you go ahead and do an ECMO. Rewarming for hypothermia might take hours together. So it's better ECMO. If you're planning for primary PCI, as I told you, if you're doing a thrombectomy, it might be for coronary thrombus or for an pulmonary thrombus. It is recommended you place them on an ECMO because long time CPR might not be possible. Resources might not be there. Any refractive hyperkalemia for dialysis, which I already mentioned. So these are the indications, or these are the things you need to keep in mind when you're starting for the ECMO. Now we are going into special circumstances. For example, if there is a pregnant lady. Your pregnant lady is less than 20 weeks of gestation. We're not much worried about. There are no much changes. It is the same algorithm what you are using. There is no additional changes. If the pregnant lady is more than 20 weeks of gestation, it is this point of the time you need to be really careful with. What are the two things additional which comes up? Additional two things is, one thing is you do an C-section. That means you do an cesarean section and deliver the fetus as soon as possible. Ideally, within 5 minutes of failure of their resuscitation, the kid has to be delivered. The fetus has to be delivered. Then place the mother in a left lateral tilt. Left lateral tilt means either you can place an wedge on the right side. So the patient goes into the left lateral state. So this is the right side, this is the left side. So you place this wedge on the right side and the patient goes into a tilt. Or you displace the fetus as shown here towards the left side. So this is the left, this is the right. You're displacing towards the left side. IVC is on the right side. So you want to avoid the compression over the IVC. Why we are avoiding the compression over the IVC? Because we want the preload to be intact, the venous return to be intact. If venous return is not there, preload will decrease. If preload is decreased, the cardiac output will decrease. Unlikely you will achieve the ROSC. For this particular reason, it is always recommended that place the mother in a left lateral position or displace the fetus towards the left side. These are the two important changes. One is the do an cesarean section and deliver the fetus within 5 minutes of failure of resuscitation. Next one is placing the mom in a left lateral position or displacing the fetus towards the left side so that the compression over the IVC is relieved. These both changes are important if the gestational age is more than 20 weeks. How do you know that gestational age is more than 20 weeks? If there is no collateral history, you palpate the gravite uterus. If it is at the level of umbilicus or above the level of umbilicus, it will be more than 20 weeks of gestation approximately. Few more things. Do we change the head position? No, it's the lower half of the sternum itself. Is the eclampsia, that means seizures in the pregnancy after 20 weeks of gestation, which has resulted in this, always give magnesium 4 grams here. It is preferred to be given. What about the defibrillative pads? Okay, they might be large, engorged, breasts might be present because of the pregnancy. It is recommended that as much as possible, place it in the same position. Okay, as you place it in any other adults, place it in the same position and the standard of use the same standard shock energies, do not change it. What about endotracheal intubation? If you have a very skilled person who can intubate the person during the CPR, then get it done. When you're doing a fast scan, you're visualizing the heart, you're visualizing the lungs. At the same point of time, have a look at the fetal heart rate also. A fetal well-being can be seen when you're doing a fast scan. That is nothing but focus, point of care ultrasound scan, what I'm talking about. Anything specifically we need to be worried about in obstetric cardiac arrest? Yes, there are high chances of these patients having an pulmonary emboli. So thrombus PE, again, we are suspecting strongly. It can be an amniotic fluid emboli also in this patient. If the patient is a known case of RHT, then it can be a mitral stenosis resulting in pulmonary edema, what we have already discussed. All this can cause hypoxia as a reversible cause. Hypovolemia, chances of hemorrhage are high in pregnancy because of the gravite uterus. The uterus can get ruptured. Uterine atony after the delivery. Placenta previa or abruptio placenta. Tamponade can happen because of peripartum cardiomyopathy you need to be aware of. Thrombus is the P what we are really worried about. There can be anaphylactic reaction. Also, our ABCD approach and correction of the coagulopathy if the patient is not in cardiac arrest, you need to be aware of. Toxins, overdose of magnesium or overdose of local anesthetic. For example, episiotomy, you're planning to do it, and you ended up giving more local anesthetic, resulted in a cardiac arrest. Then that you need to reverse the local anesthetic cardiac arrest by giving lipid emulsion. Hypothermia, one of the very important from exam point of view. Plenty of times it has come in the exams. They ask plenty of questions here. This Swiss stage classification we'll be learning in our environmental emergencies. So do not worry about that as of now. What I want you to be aware about, or I want you to be aware of this chart. Okay. By today, end of the class or after the class, I want you to really write it down and remember this and use it in your practice. Write it down in a piece of paper and stick it on your table or on your fridge and go through this. This is very important. Let me break it down. Okay. Less than 30 degrees. less than 30, not 30, less than 30. Withhold all the drugs. You're not giving any drugs. Two main drugs what we are giving are adrenaline and amiodarone. You're not giving these two drugs at all. If the temperature is between 30 to 35 degrees Celsius, double the duration. You can start giving the adrenaline if it is indicated. But you're giving the next dose on the double the duration. We usually say 3 to 5 minutes. Here you're doubling the duration. That means multiply by 2. If you multiply by 2, it becomes 6 to 10 minutes. That's why I mentioned 6 to 10 minutes what you're doing. Double the duration what you're having. Once the core body temperature is more than 35 degrees Celsius, then you are giving standard drug dosing. That means adrenaline is given every 3 to 5 minutes. There are no changes whatsoever. What about the shock? 3 shocks doesn't matter what the core body temperature is. Okay, 3 shocks, it might be 22 degrees or 29 degrees or 40 degrees. Doesn't matter what the core body temperature is. You can give 3 shocks at any body temperature. When you're giving the fourth shock, make sure the core body temperature is more than 30 degrees Celsius. The change is more than 30 degrees Celsius. I'm specifically mentioning it. Once it is more than 30 degrees Celsius, after that, it is a standard algorithm. You're following it and you're giving, you can give as many shocks as possible after 30 degrees Celsius. Okay. So first 3 shocks at any core body temperature. Once the core body temperature is more than 30 degrees Celsius, you can again start giving shocks if it is indicated. No, you're planning to stop the CPR, and when you plan to stop the CPR, you feel the carotid pulse to declare the death. Feel the carotid pulse at least for a minute's time before you declare death. That is important. Once you achieve an ROSC, that is return of spontaneous circulation, the patient might be having bradycardia. Okay, it is usually physiological bradycardia they are having for severe hypothermia. It is not indicated that you start treating the bradycardia, especially with the cardiac pacing. It is not recommended unless you feel that cardiac arrest, unless you feel that bradycardia is the one which is causing the hemodynamic compromise. For example, the patient's blood pressure is 70 systolic. So if the blood pressure is 70 systolic, and do you think it is because of bradycardia? Yes, if you think it is because of the bradycardia, then only you are intervening for the bradycardia. Otherwise, do not intervene. The patient is physiologically fine, having a bradycardia. Do not intervene. It's a physiological bradycardia because of severe hypothermia they are having. You do not resuscitate the patient. The question is, after third shock, if the body temperature does not reach 30 degrees Celsius, what do we do then? You do not give the shock. Next shock will only be given after the 30 degrees Celsius. What you'll be doing, you need to increase the core body temperature. You use the active methods and the passive method to increase the core body temperature. You're not giving any shocks. Special circumstances in asthma. Asthma is an respiratory disorder. If it's a respiratory disorder, you are suspecting an hypoxia as one of the causes. Because of hypoxia, the patient can have cardiac arrhythmias also. There's one more thing you need to be aware of, you need to be aware of is dynamic hyperinflation. Dynamic hyperinflation is also known as gas trapping. What happens? This is commonly seen in an intubated patients. Okay, once you have an ET tube, it's only seen in intubated patients. Air gets trapped in. That's why it is known as gas trapping. Air gets trapped in. It is not going out at all. It is getting completely trapped inside. So what will happen? The lungs will get expanded and expanded. So lungs are getting expanded. Lungs are getting expanded and expanded. So how do you treat it? Disconnect the ET tube what you are having from the ventilator and apply external pressure here so that all the gas comes out. So you apply the external pressure so that all the gas comes out. All the air, gas means air which is there. That's why it is known as gas trapping, which is getting trapped inside the lungs. During normal CPR, what we are doing, the back mask ventilation, with that back mask ventilation, unlikely and gas trapping to happen. But certain amount of gas trapping is always seen. Because there is certain amount of gas trapping is always seen, the amount of or the energy what you're selecting to shock the patient should be on the higher side. Okay, it is expected that there will be increased resistance because of the gas trapping which is present, increased transthoracic impedance. That means increased transthoracic resistance because of the increased air inside the lungs requires higher energies here. The standard energy, which I forgot to mention, the standard energy is 150 joules, what we give it in the cardiac arrest. Do not forget, it is 150 joules, which I have not mentioned previously. I'm mentioning here. Make a note of it. It is 150 joules shock what you are delivering. Increased airway resistance. Increased airway resistance is a lung disorder. It's an obstructive lung disease, what is present here. So the air can enter into the stomach instead of the lungs, resulting in gastric inflation. So you need to be aware of that part. So it is recommended that early tracheal intubation, if you have the skills, do an early tracheal intubation during the ongoing CPR. Tension pneumothorax. Whenever there is a cardiac arrest in the asthma, suspect an bilateral tension pneumothorax, not a unilateral, bilateral tension pneumothorax. Like what we had discussed previously for tension pneumothorax, a needle decompression followed by an ICD is preferred. For example, needle decompression, you can do it, but if you are skilled enough to do an finger thoracostomy, then do an finger thoracostomy. Finger thoracostomy is preferred over a needle decompression in an cardiac arrest patient due to an asthma having a bilateral tension pneumothorax. Now what we are learning is the traumatic cardiac arrest. It is important. What we are learning now is the traumatic cardiac arrest. So it is because of the trauma. In the trauma, everything changes. We're not following the normal ALS algorithm. Normal ALS algorithm is not followed here. This is the first takeaway message. Next takeaway message is this is followed according to the European Resuscitation Council 2021. Our latest guidelines is supposed to come this year. It has not yet been released. Might be next year. I'm not sure about it. If there is changes, I'll let you know in the group. Coming back, it is an European Resuscitation Council 2021. What is followed in the UK? You need to stick for this. If a trauma patient is come, are you suspecting a non-traumatic cardiac arrest in this patient? If yes, then follow the ALS algorithm. For example, the patient had an myocardial infarction and a cardiac arrest. That has resulted in a trauma. Then what you'll do, you will be mainly concentrating on the medical cause here. No, it is non-traumatic cardiac arrest. No, it is a trauma which has led to it. If it is a trauma, there are four important reversible causes, 2Hs and 2Ts. From 4Hs and 4Ts, it becomes 2Hs and 2Ts. Hypoxemia, hypovolemia, tension pneumothorax, and cardiac tamponade. These are the four things what you are expecting as the reversible causes in this patient. So once the patient you realize it is a traumatic cardiac arrest, you start the CPR and go according to this algorithm what is present here. First thing is you see the extremities and see any external catastrophic hemorrhages. For example, from the right upper limb, there is oozing of the blood which is present here. There is spurting of the blood which is present here. Significant blood loss is present. Then you need to control that. To control that, you might apply the direct pressure or a tourniquet, which we'll be learning in the trauma class, how to control an external catastrophic hemorrhage. But first thing is that, first step is that importance what you are giving. Second thing is optimize the oxygenation. So hypoxia is here. So you're thinking of an hypoxia might be the cause and optimize that. If required, secure the airway. To optimize the oxygenation, secure the airway if required. Next thing what you do is, still you're not sure what might be the cause for the cardiac arrest in this patient. You do an bilateral chest decompression. That is nothing but bilateral finger thoracostomy. What is finger thoracostomy? Finger thoracostomy is nothing but in the fifth intercostal space. Okay, in the just between the mid-axial line and the anterior-axial line. So this is the mid-axial line if you consider, this is the anterior-axial line if you consider. At the midpoint, you're making an hole. You make an incision, do a blunt dissection, and pierce the parietal pleura and enter into the pleural space. So what you're making a hole. If there is an air which is trapped inside the pleural space resulting in a tension pneumothorax, it gets released. This is the best way to do it. Why it is preferred over needle decompression? The problem with the needle decompression is it can get kinked. CPR is ongoing. It can get dislodged and the patient might have a recurrence of the tension pneumothorax. For that particular reason, doing a bilateral finger thoracostomy is preferred. You're done and bilateral. Bilateral means both sides you're doing it. On the left side as well as on the right side you're done it. Still you do not know the cause. Can it be a tamponade? Yes, it can be a tamponade. Or can it be an bleeding from lower down the chest level? Lower the diaphragm, the bleeding is somewhere in the pelvis or somewhere in the abdominal cavity. Yes, it can be. To treat this, you can either do an Rebova or you do an thoracotomy. There's a difference between thoracostomy and doing an thoracotomy. What is the difference? This is the thoracotomy. Opening up the chest completely is known as thoracotomy. This is known as thoracostomy. S is present here. S is absent here. This is known as thoracostomy. This is known as thoracotomy. That's the difference. How? When to do and thoracostomy. When to do and thoracotomy. Open the chest in this manner. You need to ask yourself, do you have an expertise to do this procedure? You might not be trained to do it. A consultant might be, and he might be available. That means, yes, sometimes you may not have the equipments available in the emergency department. If not available, you can't do it. Then the time elapsed is also important. In a penetrating chest trauma with less than 15 minutes of CPR, yes, do it. More than 15 minutes of CPR, do not do it. Blunt trauma with less than 10 minutes of CPR, then do it. If it is more than 10 minutes of CPR, that means it's been more than 10 minutes since cardiac arrest. In a blunt trauma, do not do it. In a penetrating trauma, it's been more than 15 minutes, then do not do it. You do an resuscitative thoracotomy, ROSC is achieved, well and good, then you will be doing an ABCD assessment again and optimize the airway breathing circulation. No, the ROSC is not achieved. Instead of doing an thoracostomy, then you consider doing or terminating the resuscitation. Then the next step here, you're not doing this or this is not indicated because you do not have the equipment or the time has elapsed, then place and pelvic splint. Start on blood products and massive hemorrhage protocol. Activate the massive hemorrhage protocol and start the blood products. So remember the sequence of the events, what is mentioned here. So you need to give the priority accordingly. Suddenly you came to know that the patient is having, for example, cardiac tamponade. In the stem of the question, the enough history is given suggestive of a cardiac tamponade. Then what you can do, then you can immediately think of doing a thoracostomy here instead of following the algorithm. Now the cause is unknown. What you do, you follow the algorithm, what is mentioned here. So you go, is there an external catastrophic hemorrhage? No. Let me optimize the airway. If required, I'll intubate the patient. Then I'll do an bilateral chest decompression. Then I'll see whether thoracotomy can be done or not. Rebova can be done or not. Then I'll be placing an pelvic binder if cannot be done. Then I'll be starting on the blood products and massive hemorrhage protocol. In all the time you're doing an CPR. CPR might not be possible to do certain procedures. For example, thoracotomy, you're not able to do it. Thoracostomy also, you might not be able to do it because the chest wall, the cot is moving a lot. If that is the thing, stop the CPR. This is not recommended in the medical cause for the or ALS algorithm. This is not suggested at all to stop the CPR. But in a traumatic cause, it is highly recommended that if you are intervening and reversible cause, what is mentioned here, for example, you want to do an thoracostomy, you want to do an thoracotomy, and you cannot do it with ongoing CPR. Stop the ongoing CPR. Importance to treat the underlying cause needs to be given rather than doing and just compression, rather than doing an CPR. You need to be aware of this is important in trauma cases. This holds good. This logic holds good. If you see the Tintinelli book or you see the OHEM or if you see the ATLS book, everywhere they are mentioned that do not do an CPR if you are not able to treat the reversible cause. The OHM goes to a certain extent that do not do an CPR at all. Okay. But as we are following the European Resuscitation Council, stick to this algorithm. This is what will be tested in your exams. Clamshell thoracostomy, what I'm doing, thoracotomy, what I said, what you do is you have already done thoracostomy. Two holes are there. You're joining the two holes here and you're opening like a clam. That's why it is known as clamshell thoracotomy. Clamshell thoracotomy might also be called as a resuscitative thoracotomy. Okay, do not get, they might just mention in the options as thoracotomy. It all means on the same. Thoracotomy, clamshell thoracotomy, or resuscitative thoracotomy, it's basically opening up the chest. There are different techniques to open up the chest. They may not do a clamshell thoracotomy. They might just do an anterior thoracotomy and lateral thoracotomy. Doesn't matter. You need to open the chest. You open the chest however you have been taught. Once you open the chest, few things you need to be aware of. You cannot do CPR. You'll do CPR on the heart, what you're seeing here. No, you cannot do CPR on the heart, what you're seeing here. So how do we do it? We do something known as cardiac massage. Okay, so if this is the apex of the heart, if this is the apex of the heart, you milk it from apex going towards the base of the heart. Okay, using one hand front and another hand in the back, you are milking how many times? Around 80 beats per minute or 80 times you milk it. How to shock the patient? Internal defibrillators are available. What we use in external padded, your small pads are internal pads are available or paddles are available. You shock the heart using it. You use the energies like 10 joules. Certain literature says you can use it around 30 joules also on the higher side. Some literature says just keep it between 10 to. So it changes from literature to literature. It changes from literature to literature, hence unlikely to be tested in the exam because there is no definitive consensus or what energy needs to be used. There might be a cardiac tamponade. Okay, you need to suture or you can staple it. For example, you open the pericardial space and drain the blood and you suture or staple the pericardium. Clamping of major laceration of the lungs can be done when you do a thoracostomy. Manual compression of the descending aorta can be done. The descending aorta, you just manually compress it. If we are suspecting an hemorrhage in the abdomen or in the pelvis, that will stop the bleeding. You can achieve the ROSC, then immediately shift this patient to the operation theater for laparotomy. I mentioned here Reboa. If you have noticed here, I said Reboa to control the proximal vascular bleeding. That means somewhere in the abdomen or in the pelvis if the bleeding is. Now let us see what is Reboa. Reboa is taking a lot of importance nowadays. They are using it in tertiary trauma centers. They are using a lot. First, we need to understand the zones. Zone 1, Zone 2, and Zone 3. Zone 1 is right from the diaphragm till or just above the renal arteries. Zone 2 is mainly the renal arteries, what it contains. Zone 3 is below the renal arteries up to the pelvis, what we are talking about, or up to the bifurcation into the iliac arteries, what we are talking about. These are the three zones what you need to be aware of. We follow a standard algorithm. What is the standard algorithm says? If the patient is hypotensive, okay, partially is responding or is not responding for the fluid resuscitation or for the major hemorrhage protocol, what you are activated and dealing with it. What you do, you access through the femoral artery. You are accessing like this from the femoral artery. You are accessing it. Line for and Reboa, you can place it. Okay, from the femoral artery access, you are doing it. First thing is always get a chest X-ray done. In chest X-ray, are you suspecting any aortic injury? That means, are you seeing any mediastinal enlargement? If there is a mediastinal enlargement is present, it is a contraindication to perform an Reboa. That means you are suspecting an aortic injury. Whenever you are suspecting an aortic injury, that is an contraindication to perform. Sorry, that is in contra. Just a second. That is a contraindication to perform and Reboa, that is restricted to endovascular balloon occlusion of the aorta, is contraindicated if there is any aortic injury. Why? You place a balloon here. For example, I will draw and place a balloon here. If I place a balloon there, what will happen? All the bleeding will happen in the thorax because the bleeding is happening here. The pressure will increase in this aorta and resulting in increased bleeding and the situation will get worsened. So that's why it is contraindicated. Next thing what you'll be seeing. Next thing is if there is no aortic injury, fast scan. Is the fast scan positive? Fast scan is basically do an abdominal scan to see whether free fluid is present. If fast scan is positive, Reboa is placed in zone 1. Okay, remember, Reboa is placed in zone 1 if the fast scan is positive. Here you are placing it because we are suspecting anywhere bleeding from here to here. That's why we are placing in zone 1. If the fast scan is negative, get an pelvic x-ray done. Okay. Is the pelvic X-ray suggestive of a fracture? Yes. That means the bleeding is from the pelvis. Pelvis means the bleeding, where it's the bleeding exactly is happening from. Here, somewhere after the bifurcation of the aorta, the bleeding is happening from. So where you want to place it, balloon? You place it in zone 3. Why can't I place it in zone 1 or zone 2? Because we want to preserve the blood supply for the vital organs which are present in the abdomen because the bleeding is not happening there. So we want to place it in zone 3 so that just above the bifurcation, if you can place it, the major arteries for the pelvis supplies is near the bifurcation or after the bifurcation. So you can stop the bleeding what is happening in the pelvis. At the same point of time, make sure that the blood supply to the vital organs in the organ are preserved. That's why you're doing that. Pelvic fracture, no, it is not there. Then still you're suspecting there is a blood loss, then place it in zone 1 itself. Because pelvic, there is no fracture, unlikely there will be bleeding. It's the fracture which causes disruption of the veins and the arteries, resulting in the bleeding in the pelvis. If there is no fracture, then do not place and rebo. Do not, sorry, if there is no fracture, do not place a rebo in zone 3. It might be still from the abdomen. You're just not able to pick it up with the fast scan. That's why you're placing in zone 1. So in a trauma, what are we suspecting are reversible causes? We have discussed this already. Hypovolemia, optimize the oxygenation. Hypoxia, optimize the oxygenation. Hypovolemia, if it's a compressible shock, that means it is compressible means the shock, compressible means the wound or the blood loss is from the extremities. Then you can apply the compression. So direct pressure, you can use novel hemostatic agents. Pressure dressing can be used. If that fails, tourniquet needs to be applied. How to apply in tourniquet? What is tourniquet conversion? Has clearly been mentioned in the 11th edition of ATLS, which we'll be discussing in major trauma. Major hemorrhage protocol activation will become important. It is recommended that whenever you activate the major hemorrhage protocol, especially in trauma cases, give calcium supplements also. Because blood is stored in a medium, that medium can result in hypocalcemia. That's why calcium supplements are recommended now. Hypovolemia, non-compressible shock, for example, where is a non-compressible? It might be in the thigh itself. It is bleeding from the bone. Okay, so the thigh is getting enlarged. So if the thigh size increases, that means more than 1.5 liters of blood is lost in the thigh because of femur fracture. So if the femur fracture is displaced, bring back to the anatomical position by placing an Thomas splint. That might stop the bleeding. Again, start with intravenous fluid and major hemorrhage protocol, add up calcium chloride, similar to an compressible hemorrhage. Tension pneumothorax, we have already discussed multiple times. You can do an lateral or an anterior thoracostomy, or sorry, thoracotomy. This is not thoracostomy. Thoracotomy can be done, or if you're well versed with the clamshell thoracotomy, you can do a clamshell thoracotomy. It doesn't matter. Cardiac tamponade, immediate thoracotomy is preferred. What if you are not skilled and you are suspecting an cardiac tamponade? As an interim measure, you can always do a pericardiocentesis. Cardiothoracic surgeon is away, he will be available in half an hour's time, then you can do an pericardiocentesis. Drowning. Are there any special? So trauma is one special. Drowning. What we suspect in drowning? Two things we'll be suspecting in drowning. One is an hypoxia. So it is recommended that you do initial 5 rescue breaths. And as soon as possible, you try to intubate the patient because hypoxia is the one of the most important causes or reversible causes in drowning. Next one is hypovolemia can be there. So IV fluids needs to be done. If the if the immersion was for more time, that means more than 10 minutes or 15 minutes, at that point of time, hypovolemia can happen. IV fluids needs to be given. When you are lifting up the patient, so drowning, this is the drowning what is happening. When you're lifting up the patient from the spot of the drowning, you need to lift it up in a horizontal position. Do not lift it up in a vertical position, because if you lift up the patient in a vertical position, venous pulling can happen. Okay, and this can worsen the prognosis for that particular reason. Can I just give and chest compression without giving and ventilated breaths? Unlikely you will get a ROSC because the primary cause here is hypoxia. Hypoxia is preferred. When hypothermia is suspected, you need to use rectal or esophageal probes are required. It holds good for anything. Okay, any cause for hypothermia, it is always recommended use an rectal thermometer or use an esophageal probe or a thermometer. Frothing can be seen here. Okay, this doesn't mean that the patient is in fluid overload. He can frothing if present. It is basically suggestive of there is there is water which has entered into the lungs, resulted in destruction of the resulted in destruction of the covering. I just forgot the word here, which helps to keep the alveoli open. It is surfactant. It destroys the surfactant. Once it destroys the surfactant, surfactant gets mixed with the water which has entered in, and this forms the bubbles. That's why you see frothing in the patients who are drowned. When you do an chest compression, froth comes out. Why does the froth comes out? Surfactant is destroyed and it has got mixed with the water which has entered into the lungs. When you're compressing the lungs, the water alveoli also get compressed. The water comes out. The water comes out in a froth form because surfactant is mixed. Special consideration for prolonged CPR. Prolonged CPR means doing chest compressions for more than 40 minutes, then it is known as prolonged CPR. What are the indications to do an prolonged CPR? If the patient is hypothermic, you usually do not declare death until you rewarm the patient. Ask them a patient, until and unless you're corrected and dynamic hyperinflation, that is nothing but gas trapping, you do not declare death. In those circumstances, you end up doing a prolonged CPR. Toxins. When you give an antitoxin or prolonged CPR, especially if you're giving a tricyclic antidepressant, you're suspecting bicarb, you're given prolonged CPR is suspected. Tricyclic antidepressants, when you're given prolonged CPR is suspected. Thrombolytics. For example, a thrombus in coronary, a thrombus in pulmonary, prolonged CPR up to 2 hours, it is recommended. Pregnancy, again, you do not declare death before you do endostative C-section. In young patients who are having persistent VF, okay, persistent VF, that is a shockable rhythm. Whenever you're having a persistent VF, or for that matter, pulseless ventricular tachycardia, especially in young individuals, it's recommended that you continue doing CPR till the patient has an asystole or goes into an PA or asystole. Or you've treated all the reversible causes, all the therapeutic options are exhausted, but still you're not able to achieve the ROSC, then you should think of stopping the resuscitation. When do you stop the resuscitation? It is guided by four things. The duration. Usually we do it for 20 minutes. Is the duration more than 20 minutes? No response to any intervention. Okay, the patient had hypokalemia, we have done it, potassium levels have come to the normal range, but still not responding. Persistently low EtCO2. Cardiac standstill. No flickering movements are also not present of the heart when you do and focus and see the cardiac, see the heart and cardiac muscle is completely standstill. These are the four things what you're looking out for. What we usually see combination of the things. Duration is more than 20 minutes. There's no response to any interventions. Okay, combination, then yes, you might have to stop it. Cardiac standstill is present. Duration is also more than 20 minutes. Yes. That is what the combination you are looking out for. Not the one parameter which directs you to stop. Only, for example, duration of CPR is more than 20 minutes. I'll stop. No, you need to look out for combination of this. If they force you in the exam and ask you which one you'll pick up and they're given the four options, these are the four options. At that point of time, always pick up cardiac standstill on an ultrasound. This is because it has 99.9% of the chances of not achieving the ROSC. Unlikely, very, very, very unlikely you will achieve the spontaneous circulation or you achieve the ROSC when there is a cardiac standstill on an ultrasound scan. There is a cardiac standstill and the duration is more than 20 minutes, just decided to stop. Then you need to confirm the death. You can't just say you stop the CPR and go and tell the relatives that he is no more. You cannot do that. You cannot go and say he's dead. You need to again do few things. Diagnosis of death, it is known as death confirmation, it is known as. You spend minimum of 5 minutes to palpate the central pulse on palpation. You listen to the heart sounds. You listen to the breath sounds by auscultating. And signs of life like movements or respiratory efforts are present. You take completely 5 minutes, you use it to check all of these things. So all combined together, you're using minimum of 5 minutes. Okay, you're confirmed there is no central pulse, there are no heart sounds or respiratory sounds on auscultation, there are no signs of life at all, like no flickering movement, no respiratory efforts are seen. Then you check for the pupillary reflex. Nothing but it's a light reflex. You flash the light. Okay, pupil needs to be constricted. Usually what happens, if you flash the light, you see the pupils have been fixed. That means they're not constricting to the light what you are exposed and they are dilated. That means more than 3 mm at least they are present and they are not responding to the light. They are fixed. Bilateral absence of corneal reflex. When you touch the cornea, you should blink. This is known as blink reflex or corneal reflex. If that should be absent in both the eyes. Absence of any motor response to an supraorbital pressure. Supraorbitally, you apply and pressure. There are no flickering movements whatsoever what you see in the limbs. If all of these are present, you take approximately 5 minutes again to do it. After 5 minutes you're done, you check it all this. Then you declare the death. What is the time of death you will declare? Time of the death is after this assessment, what is the time is shown on the clock? That will be taken as time of the death. So to summarize, RCAM has said minimum what needs to be done is this. So first, confirm the identity of the patient, then assess for the response to pain by applying the supraorbital pressure, then assess for the light reflex, that is pupillary response, see whether the pupil is dilated and fixed, palpate for and carotid pulse, listen heart sounds for at least 2 minutes, listen for breath sounds at least for 3 minutes. All of these are absent. At that point of time, you declare death. At the end, what time is shown in the clock, that time you will take it as the time of the death, not at the time when you stop the CPR. Sometimes we do get an ROSC. The return of spontaneous circulation can be achieved sometimes. At that point of time, what you do, how do you assess? You go ahead with an A, B, C, D, E assessment. In airway and breathing together, what we are looking for to optimize the SpO2 values to around 94 to 98%. For this, if required, place an advanced airway like an endotracheal tube. Most of the time, it will be required. Attach an waveform capnography and confirm that the endotracheal tube is in C2. And get a chest X-ray also done to see at what level the endotracheal tube is there. Next one is circulation. In circulation, a 12 lead ECG is required, and maintaining or optimizing the blood pressure is important. To optimize the blood pressure, see whether the patient has normovolemia or not. That means use an ultrasound scan, see the IVC inferior vena cava. If it is compressible, that means you need to give more fluid. So start giving more fluids. No, it is distended and non-compressible, then you need to start on vasopressor agents. If you are skilled enough, place an intra-arterial blood pressure monitoring. That means arterial line needs to be placed and intra-arterial blood pressure monitoring is always preferred. Controlling the temperature. This is also known as therapeutic hypothermia. Therapeutic hypothermia means maintaining the core body temperature between 32 to 36 degrees Celsius. This is usually done in intensive care unit rather than in the emergency department. All right. And while you're reducing the core body temperature, they might develop shivering. Then you need to sedate the patient, like using an benzodiazepines, you might have to sedate the patient. So this is not done in the emergency department most of the time, but you need to be aware of therapeutic hypothermia. What is the temperature they maintain? They might ask question in that manner. It is 32 to 36 degrees Celsius. Is there a likely cause for cardiac arrest? If yes, take an 12 lead ECG. Okay, if it is suggestive of an ST segment elevation, immediately involve the cardiologist, get an angiography. If required, do and stenting also, that is percutaneous intervention. No, there is no ST segment elevation. Consider, are you suspecting an STEMI? They are asking. Yes, then go ahead with an angiography and angioplasty. No, you're not suspecting. There is a classical history and he cardiac arrested. There is no ST segment elevation, but still you're suspecting an STEMI. Yes, then you go ahead and get it. No, you're not suspecting. Then, is the cause for an cardiac arrest you have found out? Can be an electrolyte imbalance or an toxin? No. If you're not found out the cause, get an CT brain and CTPA done in the same setting. It is recommended to get both done. Then you admit in the ICU. If you identify the cause, then need not get NCT brain and CTPA done. Directly, you can admit in the ICU. If not, get the scan done, then immediately admit in the ICU. What happens in the ICU is for the intensivist, not for the emergency physician. That's why we're not going through this. Few things what you need to be aware of. In avian breathing, I said you need to intubate the patient. If the patient has some amount of tone, then you need to sedate the patient and paralyze the patient. That means rapid sequential intubation by giving drugs. Like you might be giving a succinylcholine for skeletal muscle relaxant. For induction, you might be using a propofol. For pain management, you might be giving a fentanyl. Then you will be intubating. Before you give this sedating and paralyzing agents, it is recommended that you document what is the GCS pupils and what is the GRBS. This is important for the prognostic point of view. Okay, intensivist will be seeing what was before you give the sedation and paralysis. Once you gain sedation and paralysis, it becomes difficult to assess what is the GCS, what is the pupil size, are they responsive or not. That's why. An unconscious patient is at greater risk for unrecognized hypoglycemia. The sugars might fall down. So be cautious about the glucose levels and try to maintain the blood pressure values less than 20 millimoles, but more than 6 or at least 5 millimoles you need to be maintaining. Not at the very low level, at least 5, between 5 and 20 you can maintain. If the patient is having high core body temperature, the outcome will be worse. You need to immediately reduce the core body temperature. What it is causing? Is it the seizures which is causing? Then paralyze the patient. Give antiepileptic medications to stop. If it doesn't stop, paralyze the patient. It is the fever which is causing it because the patient is in sepsis. Give antipyretic agents like a paracetamol or NSAIDs can be given. Absent pupillary reflex or absent motor response to the pain are not of prognostic value soon after the ROSC. It is the prognostic values after 72 hours after the ROSC. This is mainly because you are given adrenaline. Adrenaline causes pupillary dilatation and it may not respond to the light reflex at all because the pupil is dilated so much. There's nothing left. It may not constrict it at all. For that reason, they are told that pupillary reflex as well as the absent motor responses are not important immediate after ROSC. They are important after 72 hours of achieving the ROSC. What about advanced age is suggestive of a poor neurological outcome? Absolutely wrong. Not. In capital I've written no. If the pH is less than 7.05, the outcomes are usually worst after ROSC. Okay, you have achieved the spontaneous circulation, you get an arterial gas done, and arterial gas shows the pH is 7.05, less than 7.05, it might be 6.9. The prognosis is usually bad. Now we are entering into tachycardia and bradycardia algorithm. Both tachycardia and bradycardia algorithms mention life-threatening features. There are four life-threatening features they have spoken about. Is the shock, syncope, severe heart failure. Remember the word severe here. They're not just talking about heart failure. It's severe heart failure. Fourth one is myocardial ischemia. What they are trying to tell life-threatening features. Are these life-threatening features? Always ask yourself, are these life-threatening features or because of the arrhythmia? Okay, for example, the patient is having an atrial fibrillation. Because of atrial fibrillation, the patient has gone in shock. Because of atrial fibrillation, the patient has gone in syncope. That's what you are asking yourself. What do I mean by shock? Shock, grossly for us, core body temperature, sorry, grossly for us, systolic blood pressure being less than 90. Or it can be other things also. It might be a reduced blood supply to the brain or increased sympathetic activity. For all practical purpose, two things you are looking for in a shock patient. Shock, if you want to consider the systolic blood pressure should be less than 90, or the patient should be disoriented or in the altered sensorium, which suggestive of a decreased blood supply to the brain resulting in encephalopathy. Altered sensorium. Okay. So two things you're looking for shock. One is the systolic blood pressure less than 90, or the patient is in altered sensorium. Syncope. Is there anything suggestive of a transient loss of consciousness? That means reduced blood supply to the brain. Or again, they're talking about severe heart failure. That means the patient should be breathless or breathless because of a pulmonary edema, or the saturation should be on the lower side because of the pulmonary edema. That means severe heart failure he is having. Right-sided heart failure, if you're considering right JVP should be present. Myocardial infarction. It becomes very difficult myocardial infarction. Did the patient have any classical signs and symptoms suggesting of an angina resulting in an tachycardia? Or tachycardia has resulted in a classical chest pain? Or the patient having an isolated event of an ST segment elevation on a chest leads on an ECG, 12 lead ECG you are taken and resulted in an ST segment elevation? Can be a possibility because of an arrhythmia. If you're thinking that is the possibility, then what you need to do it, you need to treat it as a life-threatening feature with an arrhythmia the patient is having. This one, you need to be very much careful when you're considering a myocardial ischemia, because myocardial ischemia can trigger an atrial fibrillation. Myocardial ischemia can trigger an ventricular tachycardia, can trigger an ventricular fibrillation. So you need to be that much more careful when you're considering an myocardial ischemia. When you need to really consider myocardial ischemia as a life-threatening feature due to an arrhythmia, if they mention only chest pain, okay, no ECG or ECG has been given, there is no ST segment elevation, then consider the chest pain is because of the arrhythmia. Arrhythmia has resulted in reduced blood supply to the myocardium, resulted in a chest pain, yet to develop an ST segment elevation because they are immediately presented to the AD. That's how you need to consider the myocardial ischemia. So, as we are aware of the life-threatening features, now we will be studying about tachycardias and bradycardias. First, let us study about the tachycardia per se. First, I will go through the tachycardias, then I will be going through the bradycardias. Tachycardias. First assessment, everybody forgets this. You do first thing is ABCD assessment. When you are doing an ABCD assessment, if the patient is hypoxic, you give the oxygen. This is before even thinking about whether I need to shock the patient or treat the shock. No, if the patient is hypoxic, you give the oxygen as the first step. Obtain the IV line. Get an ECG done. Check the blood pressure, saturations, record and 12-lead ECG. Identify identify and treat the reversible causes. Like an electrolyte abnormality is present, hypovolemia is present, or myocardial infarction is present where you need to get an PCI done. Get it done here. You got into early TCG, which shows an ST segment elevation. Get an PCI done before treating the patient. Another thing what you need to be aware of. Okay. I spoke about myocardial infarction. This is a tricky part. That's why I'm mentioning again about the myocardial infarction. Myocardial infarction see to the patient as a whole. As a whole, you are seeing the myocardial infarction. So a patient with an AF plus and myocardial infarction plus the patient is unstable. For example, systolic blood pressure is less than 90. Then what do you do? then you treat this AF. Instability might be because of AF. Treat the AF before you get an PCI turn. So you will treat the AF first. He has an AF, plus he has a myocardial infarction, but the patient is stable. What do you do first? You do a percutaneous intervention first. You treat the underlying cause. The patient is stable. Why you want to really mingle with the arrhythmias? Treat the underlying cause. The underlying cause is treated. AF will get treated by itself. You need not do anything. That's the logical thinking what you need to have. So do an ABCD assessment. Some reversible causes, treat it before you think of a shock or in particular treatment. For example, he has a drug overdose. Give an antidote before thinking of a life-threatening feature. Now coming to the life-threatening feature, which we have already discussed. If the life-threatening feature is present, what you do is you shock the patient. Shock is a synchronized shock you are giving. That means shock needs to be delivered before the Q wave. P, Q, R, S. So before the R wave, to be more precise, before the R wave, you need to deliver the shock. If you deliver over the R wave or if you deliver over the T wave, it can worsen. That's why it is recommended that you always use synchronized shock. If you do not synchronize the shock, you will worsen the condition of the patient. That will be a disaster. If the patient is awake, that means if the patient is conscious, always sedate the patient before you give the shock. If unsuccessful, you keep on repeating for 3 times. But before the 4th attempt you give it, call for the expert. So you're given 3 shocks. You plan to give the 4th shock. Hold on. Do not give the 4th shock immediately. Call for the expert help. Give an amiodarone bolus. Bolus means 300 mg IV to be given over 10 to 20 minutes. Then deliver the 4th shock. After the 4th shock, still you have not achieved the normal sinus rhythm. Then you start on amiodarone infusion. That is 900 mg is given over 24 hours of duration. After this, what you do? You start the infusion and you call for the expert. This is out of scope of an emergency physician at this point of time. There are no life-threatening features. That means you need to look at the QRS complex. Is the QRS broad? Broad means more than 3 small boxes or less than 3 small boxes. That becomes important. If it is more than if it is more than 3 small boxes, then you will be checking for the rhythm. Is it a regular rhythm or is it an irregular rhythm? If it is a regular rhythm, consider as an ventricular tachycardia and treat it with amiodarone. Latest literature says that, including RCAM, which was released in 2023, says that amiodarone might not be helpful. You either shock the patient or use ensotolol for this patient, what has been recommended. Okay. But for exam point of view, I still want you to stick to the amiodarone itself. So there shouldn't be any confusion. You come back in RCAM learning it is preferred. But what happens in exam is they stick to the ALS. What is mentioned in the ALS? Amiodarone. So you end up giving amiodarone. What else rhythm can be, which we already learned in the ECG chapter? It can be an SVT with an aberrant block. That means SVT with an bundle branch block. How do you treat this patient? Like an SVT itself, no changes. If you're suspecting an SVT with an aberrant block. If it is a irregular, but it is a broad QRS complex, what are we suspecting? It can be a polymorphic VT where you're treating with an magnesium sulfate. This torsity point is also known as. It might be an atrial fibrillation with an bundle branch block. Can it have irregular rhythm? Yes. Can it have a broad QRS complex? Yes, because of the bundle branch block, they can have a broad QRS complex. How do you treat it? Treat it like an AF. So let us see the ECG, how it appears. This is an atrial fibrillation with an bundle branch block. Why do you see an atrial fibrillation? Do I see any P waves? There is no P wave which is present. There is no P wave at all which is present. Is the rhythm regular or irregular? It is irregular. If you take this RR interval to this RR interval, it is different. It is irregular. So it is an atrial fibrillation. Atrial fibrillation is supraventricular tachycardia. Why does it has an broad QRS complex? Because there is an associated M pattern is present here, which is suggestive of an left bundle branch block. So this is an AF with left bundle branch block. That's why it becomes here. If you go, it becomes an irregular rhythm. Now let us discuss about narrow QRS complex. Narrow QRS complex irregular, it becomes an AF. AF, what we have learned, follow that. Okay, when it is a stable AF, we have already learned in much more detail, follow that what we have learned. Okay, additional thing, if there is a structural abnormality, we are using amiodarone, which I already posted. Okay, So what to use, everything, nice guidelines, what we have discussed is according to the nice guidelines. So he's sticking to the nice guidelines and treating accordingly. Here, what they are given very briefly. If you go in depth and read about the ALS book, they have given in depth at that point of time. So stick to what we have learned in the cardiology chapter. Rhythm is regular. What are we suspecting? Supraventricular tachycardia. So what we will do? First step is vagal maneuver. Okay, vagal maneuver, you can do it in plenty of ways, like applying pressure over the globe can be done, or carotid massage can be done. You might ask the patient to blow the air in the syringe, you can do it. So there are plenty of methods. Vagal maneuver is the one thing what you need to be aware of. If that is ineffective, then you are giving adenosine. Okay, when you are giving adenosine, again, they are mentioned, if no pre-excitation, that means is not a known case of WPW syndrome or is not a case of LGL syndrome. Okay, there is a little bit controversial here. Okay, for example, in a narrow QRS complex, I said treat it like an SVT. Okay, so whether we treat it like an SVT with a narrow QRS complex or whether how do we treat it is the question which comes. It is always recommended that if you are sure it's a WPW syndrome and the patient is stable, this was for an unstable patient. All right. It's very difficult. It's an unstable patient. We usually shock. Narrow QRS complex. Do I treat it with an SVT like an SVT here, which we learned it in the ECG chapter, or how do we treat it? Again, it is recommended that you still treat it as an SVT with an cardiology review. A cardiologist needs to be present at that point of time. If you're suspecting an SVT or you're suspecting any other rhythm because of an accessory pathway, it is always recommended that use the cardiologist. Cardiologists usually say give adenosine for those patients if it's a narrow QRS complex within WPW. So that is a bit complicated, unlikely to be tested in the exam. They will stick to what is very clear because both the answers will be correct in the exam. That kind of questions doesn't usually appear in the exam. If we are suspecting an SVT, vagal maneuver is ineffective, then what you do? You give adenosine 6 mg rapid bolus. That is not effective, 12. Increase the dose to 18 if that is not effective. Continuous ECG monitoring is required. You given adenosine, the patient has not responded. What are we thinking? It may not be an SVT, it can be an atrial flutter, what we are thinking. That's why we end up giving an calcium channel blockers like verapamil or diltiazem, or we can give an beta blocker. It's still ineffective, then you go ahead and shock the patient. If the patient is conscious, always sedate the patient. Remember, when we give the synchronized shock, general thumb rule is whenever the patient is not in cardiac arrest, we give synchronized shock. If the patient is in cardiac arrest, we just give asynchronized shock. Asynchronized shock for cardiac arrest only. If the patient is not in cardiac arrest, we always give synchronized shock. Remember that. Same thing holds good for an VT. The patient is not responding after giving amiodarone. What do? We go ahead and shock the patient. This we have learned here. Quick recap so that you are aware of the rhythms. This is nothing but SVT. This is nothing but atrial fibrillation. Atrial flutter. What we are having. This is an atrial fibrillation where there is no P wave, irregular rhythm. Sawtooth appearance, atrial flutter. Narrow QRS complex, heart rate more than 180. Most of the times SVT it is. So SVT, flutter, and atrial fibrillation. Along with it, junctional rhythm you need to be aware of where there is no P wave, but the rhythm is regular. Usually the heart rate will be between 40 to 60. Anything more than 60, you will consider it as an accelerated junctional rhythm. QRS complex, if it is broad, it can be an VF, it can be an VT, that means monomorphic VT, or it can be an Torsati point, is also known as polymorphic ventricular tachycardia. Be aware of non-sustained ventricular tachycardia. When 3 or more PVCs are present consecutively, but after that there is a normal rhythm, then we call it as a non-sustained ventricular tachycardia. Remember that ALS cannot be applied for a non-sustained ventricular tachycardia. Let me see if you have anyone has any questions. Lightheadedness, palpitation in a history cannot be considered as a life-threatening species. Yes, lightheaded, no. There should be a loss of consciousness. Just I'm being dizzy. I feel like I'm gonna black out. I feel like I'm gonna fall down. I feel I'm having a spinning sensation. All those doesn't matter. So life-threatening features, you need to be very careful. It's a syncope. Transient loss of consciousness should be present. Severe heart failure should be present. MI should be present. Okay, shock should be present. Then only you call it as a life-threatening feature. Otherwise, it is not a life-threatening feature. Bradycardia. Similar to tachycardia, you always do an ABCD approach. If the patient is hypoxic, give the oxygen first, get an IV access done, connect to the cardiac monitor, get into a lead ECG done. If you feel there is a reversible cause like an electrolyte abnormalities or an toxin overdose like a beta blocker overdose, treat that first. Then you are looking for life-threatening features, same shock, syncope, myocardial infarction, severe heart failure. If present, what you do? You give an first dose of atropine. Okay. If not present, that means no life-threatening features are present. Then what you do? Then you see is there a risk of asystole is present. Risk of asystole is recent asystole. That means recently he had an cardiac arrest. Morbid type 2 AV block is present. Okay, we already learned what is Morbis type 2. Morbis type 2 AV block is present. Complete heart block with a broad QRS complex is present. Or in ventricular pause for more than 3 seconds. What is ventricular pause for more than 3 seconds? So you have an QRS complex here. Another QRS complex is after 3 seconds. This is known as ventricular pause. Doesn't matter what the P waves are there. So one QRS complex is away from another QRS complex for 3 seconds. This is known as ventricular pause for more than 3 seconds. If any one of this following is present, or the patient is not satisfactorily responded to an atropine, then you go to this box. In this box, what do we do? Step 1 in this box, give more doses of atropine. Maximum of 3 mg can be given. That means 6 doses of atropine can be given. How long you need to wait it for? You can wait for 1 or 2 minutes and give one more bolus. Okay, there is no exact duration what has been mentioned. They have mentioned that back to back you can give the doses. Then comes is basically infusion drugs or transcutaneous pacing. Which one to be preferred? Preferred one is transcutaneous pacing. Transcutaneous pacing, for some reason you cannot do it. That's when the infusion is preferred in normal circumstances. Remember, step 1, give more doses of atropine up to 3 mg. Not responded, then you're going for the transcutaneous pacing, not for the infusion. Transcutaneous pacing is preferred over giving an infusion, which is clearly written in the ALS book. After this, immediately seek for the expert help because they will be requiring an transvenous pacing. Alternative drugs can be given. See here, it is mentioned alternative drugs. For example, transcutaneous pacing is not possible. Atropine maximum dose you are given. Instead of isoprene or adrenaline, you can give aminophylines, dopamine can be given, glucagon can be given if you're suspecting a beta blocker, calcium channel blocker overdose. Glycopyrrolate can be given if you're suspecting, instead of atropine, you can try glycopyrrolate can be given. These are the doses what have been mentioned. The dose, what you need to remember is 0.5 mg atropine is the most important dose. What do you need to remember? The rest of the doses, we usually follow the local protocols. If you can remember, well and good, it will be helpful in your practice also. So first thing we need to learn is how to give an transcutaneous pacing. Transcutaneous pacing is given by the defibrillator. You need to select the pacer mode first. Okay, on the defibrillator, there will be a knob. Select it to the pacer mode. Once you are selected to the pacer mode, then you need to select whether it is a demand mode or a fixed mode. Fixed mode is outdated. Okay, it is the demand mode which is present. Fixed mode is outdated. All right, demand mode which is present. What is demand mode? Demand mode is basically if the patient is having a bradycardia, then only it goes. So you have, for example, you have set the heart rate to be at 670. So it makes sure the patient has a 70 heart rate. Sometimes they might have its own heartbeat. If it has its own heartbeat, it will not. This is fixed. You can see here at a fixed interval, it is delivering the electrical activity to the heart. Here it doesn't deliver at the fixed because heart is pumping at the 70 rate. So I will not deliver the electrical activity. If it goes low, then only I will deliver. That means it is only on the demand. If it goes low, then the demand increases. Then only you are giving, then only the machine gives the electrical activity. It is a little bit more theoretical for you. It's only the demand mode which is present. If you can remember that much, that should be sufficient. Placing the pads. Pads, the same position how you place it. Okay, more on the lateral side or from the apical side to the more on the lateral side, you can place it. Okay. Another one is just below the right clavicle, what you're placing it. Usually a diagram would have been mentioned over the pads where it needs to be placed in. Or you can place it anterior posterior like it is shown in the picture here. You can place it in the anterior posterior mode. Once you have selected the pacer and it is in the demand mode, and it will be usually in the demand mode in the all latest defibrillators which are available in the NHS. Two things you need to set. One is the heart rate. So rate you're testing. Rate is usually set at 70 beats per minute. We do not want very high. We do not want at the borderline like 60. So optimum will be 70 to place it. Then pacer output is the energy. Pacer output. Pacer output is fixed at 30 milliamperes. Okay. Then what you do? Then you assess the cardiac monitor. Assess and see after every electrical activity, is there a QRS complex? Yes. Yes. After this electrical activity, there is absence of QRS complex. After this electrical activity, there is absence of QRS complex. After this electrical activity, there is absence of QRS complex. If this is the situation, what you need to do, you need to keep on increasing the energy. That means you keep on increasing the pacer output. So how much from an increment of 10, from 30 to 40, 40 to 50, 50 to 60, you'll be keep on increasing till you get this rhythm. That means after every stimulus, there is an electrical activity. After every stimulus, if there is an electrical activity, this is known as electrical capture. Once electrical capture is present, next thing what you do, you need to look out for a mechanical capture. What is mechanical capture? You have an electrical activity and in the monitor it is showing 70 beats per minute what is present here, and this is satisfied. Then you check the pulse. You can use any pulse like a radial pulse or a femoral pulse or a carotid pulse. You check for the pulse. Pulse also should be 70 beats per minute or more than 70 beats per minute. If it is less than 70 beats, for example, it is only 40 beats per minute, that means electrical activity is present, but the heart is not compressing at the rate of 70 beats per minute. It is only compressing at the 40 beats per minute. That means mechanical capture is not present. If it is beating at 70 beats per minute, that means both electrical and mechanical capture is present. If it is not beating, mechanical capture is not present. If mechanical capture is not present, what you do? Again, you continue increasing the energy. For example, at 60, you got the electrical capture. Then you increase 70 and see whether you got a mechanical capture. 90, you got a mechanical capture. That means your pacing has been achieved. No, you're not getting the mechanical capture at all. You have reached the maximum. Maximum is usually around 120 to 130 milliamperes. Without any mechanical or electrical capture, you reach the maximum. What you do at that point of time, change the position. Change the position from this position to and this position. That is the anterior posterior. Still, if you do not get it, that means myocardium is non-viable. Non-viable myocardium, what you are having. Is sedation required for cardiac pacing? Most of the time, sedation is not required. If the patient is very sensitive to the pain, then sedation might be required at that point of time. Otherwise, most of the time, sedation will not be required. Bradycardia plus life-threatening features are present. Okay. Special circumstances I'm talking about. This is special. That are all what was usual. Special circumstances. A patient has a myocardial infarction or a spinal cord. You're giving a first dose of atropine. He has not responded after first dose. That means you're given 0.5 mg of atropine. He has not responded to the 0.5 mg of atropine. Then what you do? You give aminophylline. In a cardiac transplant patient, atropine is contraindicated. Directly, you're giving aminophylline. In regular dose of beta blockers, someone is on a regular dose of beta blockers. Give first dose of atropine and see whether they are responding or not. That means 0.5 mg of atropine you are giving. If they're not responding, then you start an adrenaline infusion. Someone is an overdose of beta blocker or in calcium channel blocker overdose he is having. Then you give glucagon. When to give glucagon? First, before atropine itself, you are giving an glucagon here. Okay, you need to follow this sequential order. Cardiac basic life support before, sorry, pediatric basic life support. Before I go into it, there is a question, sir, in a hypothermia after shock and first dose of adrenaline, you mentioned amiodarone 300. Second dose, you mentioned 900 infusion. I do not understand what is the dose. I'm not sure what you are mentioning here. There is a difference between cardiac arrest, hypothermic cardiac arrest, or cardiac arrest patients where we give 300 and 150. 900 infusion, what I mentioned, is in the tachycardia algorithm where the patient is not in cardiac arrest. I'm not sure what is the confusion you are having. Pediatric basic life support. Okay, pediatric basic life support. If the patient is unresponsive, what do? You immediately call for the help. Okay, check whether the patient is responding. Open the airway if the patient is not responding, and then you start checking whether the breathing is normal. This is very important. In pediatric age group, we are not depending on the carotid pulse or the central pulse. Usually, carotid pulse is not checked. Brachial pulse is what is checked in the pediatric age group. Remember that usually a brachial pulse is checked in the pediatric age group, not the carotid pulse what you check in the pediatric age group. Okay, we check for the brachial pulse also. If it is not present, you will consider as an cardiac arrest. But most of the time in pediatric age group, hypoxia is the cause for the cardiac arrest. That's why breathing is there or not, you need to consider. If the breathing is not there, patient is in respiratory arrest. If the pulse is present also, you need to consider this patient. You need to consider this patient as not having normal breathing and signs of life are abnormal. Then you directly go for fire rescue breaths. No, the patient has normal breathing, their brachial pulse is present, then you go for an ABCD assessment. Fire rescue breaths. Okay, fire rescue breaths, each breath is given over 5 seconds. So remember, in pediatric, fire rescue breaths are given first. After fire rescue breaths, you reassess the patient. Okay, reassess the patient, see whether the patient has started breathing. Is there a central pulse present? When you reassess, no, there are no signs of life. The patient is not breathing or there is no brachial pulse is present. Then you start the compression at the ratio of 15:2. Here it changes. It is 15:2 chest compression what you are starting. Immediately connect to the defibrillator and ECG monitoring, whichever is immediately available, but defibrillator needs to be connected. Then you enter into the advanced life support. Before we enter into advanced life support, pediatric, depending on the age, the drug doses and the size what we are using changes drastically. So you need to be aware of wet flag. Wet flag is a mnemonic to be where W stands for weight, E stands for electricity, T stands for endotracheal tube size, F stands for fluid, L stands for lorazepam, A stands for adrenaline, G stands for glucose. These are the formulas you need to remember it. There is no shortcut for this. However you want, you remember. What I want is remember this. Okay. Electrical shock or the energy what is given in a patient with a cardiac arrest is 4 joules per kg. Be aware of it. It is 4 joules per kg what you are giving. ET tube size, the internal diameter. If they are not mentioned cuffed or uncuffed, for example, here tube what you are seeing, it has a cuff here. It doesn't have any cuff here. This is an uncuffed ET tube. This is an cuffed ET tube. Preferred one is which? Cuffed ET tube what we are using nowadays. Okay, unless and until the patient is preterm. If it is a preterm, then we use uncuffed. Otherwise, anyone, any age, if it is not a preterm, then we always used and cuffed. That's the preferred one what we are having. Plenty of questions have appeared previously. Twice or thrice it has appeared where they are asked to calculate the internal diameter of the ET tube. They're not mentioned whether it is a cuffed or whether it's an uncuffed one. If they are not mentioned, what you do, 8 divided by 4 plus 4. If they are specifically mentioned, it is a cuffed one, then use 8 divided by 4 plus 3.5. If it is uncuffed, 8 divided by 4 plus 4. It is the millimeter. You get the size. Preterm, 3 mm, uncuffed. Up to 6 months, 3.5 mm cuffed. 6 to 12 months, 4 mm cuffed. Next thing is fluids. It might be traumatic or atraumatic cause. Fluids have kind of standardized to give around 10 ml per kg. Lorazepam 0.1 mg per kg you need to be aware of. Adrenaline dose, it's basically 0.1 ml per kg of 1 is to 10,000 dilution. It's nothing but 10 micrograms per kg what you'll be giving. Okay, 0.1 ml per kg of 1 is to 10,000 dilution needs to be given. Same as adult dilution wise. Here you're giving 0.5 ml I'm talking about, not mg. If you're talking about the mg, it is microgram. 10 microgram per kg you're talking about. If you're giving through an ET tube, it becomes 100 mics per kg of 1 is to 1000 dilution, not 10,000, 1000 dilution. That is approximately 0.1 ml per kg of 1 is to 10,000, sorry, 1 is to 1000 dilution. Glucose, the patient is hypoglycemic, how much you give it? You can give from 2 to 5 ml, up to 5 ml also you can consider giving it. 2 to 5 ml is the range. Minimum is 2. Maximum we can go up to 5 ml of 10% dextrose. We are not using a 50%, 25% dextrose here. So what are the changes? It is quite similar. You start with the BLS where you are given 5 rescue breaths. You connected, then you started the CPR at 15:2 ratio. Then you assess the rhythm. Same thing, no changes. Shockable is same thing. VF for pulseless ventricular tachycardia. You give shock as soon as possible. Immediately after the shock, you resume the CPR for 2 minutes. Then again you reassess the rhythm. This time it might be an pulseless electrical activity like PEA. Sorry, pulseless. It might be a pulseless electrical activity. It might be a systole, or this is the where people miss it. Or what is the additional thing where people miss it? Bradycardia. Heart rate less than 60 in an unconscious patient. We consider this as an cardiac arrest in a pediatric age group. Do not forget this. This way the people forget. Yeah, PEA, yes. Asystole, yes. Heart rate less than 60 with a pulse. Still, it is a non-shockable rhythm. You need to consider as an cardiac arrest. Immediately resume CPR for 2 minutes. You give adrenaline first dose and repeat it after 3 to 5 minutes. Everything remains the same. If you achieve an ROS post cardiac arrest algorithm, what we have learned, same thing, nothing changes. So what are the changes? Changes is 5 rescue breaths needs to be given first, followed by 15:2 CPR, what you will be giving. Heart rate is the important part here. Pulse might be present, but the heart rate less than 16 and unconscious present, you would still consider as an cardiac arrest. This is what has been mentioned here. You need to be aware of. Along with it, the adrenaline dose changes. You need to be aware of the adrenaline dose. So adrenaline dose, how much you are giving, you need to be aware. Amiodarone dose, how much you are giving, you need to be aware. Whenever you are giving shock in a cardiac arrest patient, shock, how much you give it? 4 joules per kg, you need to be aware of. That is the cardiac arrest algorithm. You just remember the differences similar to adult. If you remember the adult, just remember the differences. Pediatric becomes very easy. Here, Brady and Tachy algorithm are combined together. It is a rare entity to see an bradycardia or tachycardia in a patient in a pediatric age group, basically. The approach remains quite similar. The approach here is first you do an ABCD assessment. If you recognize, treat the reversible cause first. Here, they are not telling treat the signs of circulation. At any point of time, it is not their ALS, it is a cardiac arrest. Here, they're not mentioning life-threatening features. Instead, they are using whether the kid is decompensated or compensated. Compensated means all his vital parameters are in the normal range. Then what you will be doing? Treat the cause. Is the bradycardia because of hypoxia? Treat with oxygen. If the SVT is because, if SVT is present, consider vagal tone. If that is not working, consider giving adenosine. Now coming here, if the kid is decompensated, decompensated might be because of reduced GCS, low blood pressure, CRT elevated, weak or impalpable peripheral pulses. It can be because of brady or tachycardias. It can be because of brady or tachycardias. But do not consider just an tachycardia as a decompensation. Along with the brady tachycardia, one of these following should be present. Okay, they are talking about extreme tachycardias and bradycardias. In extreme tachycardias and bradycardias, there will be some compromise. So for exam point of view, they should mention one of these following for you to consider as an one of these following should be mentioned for you to consider as a decompensated heart failure. That means along with the bradycardia or along with the tachycardia, one of these following if present, then only consider the kid to be decompensated. First, let us see bradycardia. In less than 1 year, bradycardia is less than 80 beats per minute. In more than 1 year, the bradycardia is less than 60 beats per minute, similar to adults. So less than 1 year, remember it is 80. How do you treat it? Most of the time, bradycardia is because of low saturations or low saturations or because of hypoxia. So because of hypoxia, it is present. What you do, give oxygen, increasing the saturation level. If the patient, even after giving oxygen, the patient remains unconscious. Remember, you are already given oxygen as a first step. Second step, you are noticing that the patient is unconscious and heart rate is less than 60. Consider this to be an cardiac arrest and start on chest compression. Okay. Again, let me repeat it. You're given oxygen, then you are checked, the patient is unconscious and the heart rate is less than 60. Then you will consider this as a cardiac arrest and start on the chest compression. There is no response to the oxygen. You started on chest compression. If you feel there might be a vagal stimulus, give them an atropine. They're not responded to the oxygen and atropine, then you can consider giving adrenaline That means follow the normal ALS algorithm. It is very rare to go to this extent. Usually they'll respond to the oxygen. If not responded to the oxygen, they'll respond to the atropine. If not responded to the atropine, they respond to the adrenaline. One thing we need to be aware of is this part where people get confused and forget about it. Tachycardias, like adults, they are divided into narrow and broad complex. Narrow means it can be an sinus tachycardia. The thing with the sinus tachycardia is in infants, if the heart rate is less than 220, you will consider as in sinus tachycardia. For example, someone is having 200 heart rate in an infant. It becomes very difficult to see whether I can see a P wave or not. 200 beats per minute. QRS complex is so close by P wave may not be appreciable there. So, to decide whether it is a sinus tachycardia or an SVT, especially in an infant, depend on the heart rate. If the heart rate is more than 220 in an infant, consider as an SVT. If it is less than 220 in an infant, consider as a sinus tachycardia. In child, it is less than 180, more than 180. Okay. Usually, sinus tachycardia is gradual onset. SVT is abrupt onset. Sinus tachycardia, if present, treat the underlying cause. It might be because of crying, console it. It might be because of anxiety, pain, or it might be a compensation for an anemia, hypovolemia. Treat the underlying cause. SVT. SVT, what we do? The patient is decompensated. Preferred one is shock the patient. Okay, what shock we give? You give an synchronous shock. How much we give? We started with 1 joule per kg. And you can increase, if they're not responding for 1 joule per kg, you can increase it to up to 4 joules per kg. That is the max. All right. If for some reason the synchronized shock, what you're planning to give the patient, okay, you're not able to give it immediately. For example, for sedation, you're not getting a pediatric anesthetic because if the patient is conscious, you need to sedate it. You do not have a pediatric anesthetic. It is getting delayed. At that point of time, chemical cardioversion can be chosen as in first choice by giving adenosine. Okay. So remember, let me repeat it again. Shock is preferred. If shock delivery is getting delayed, then you can give adenosine. That's as simple as that. If the kid is awake before giving shock, you need to sedate it. Same thing as adult. Here, when you are giving amiodarone, okay, there in adult, we give it after third shock. Remember, after third shock. Here it is before third shock. That means after second shock, amiodarone is given here. Now, broad complex VT. Broad complex VT, if the patient is conscious, sedate him and give the shock. If the patient, if the patient is conscious, sedate him and give the shock. If the patient is unconscious, then what you do? Then you need not sedate him. You can immediately give the shock. Same thing holds good here. After the second shock, you deliver the amiodarone or you give the amiodarone. Okay. Remember, synchronized shock is given to any patient who is not in cardiac arrest. Asynchronous shock is given to any patient who is in cardiac arrest. Holds good in pediatric age group also. You are supposed to be learning all these doses, what has been mentioned here, including the systolic blood pressure, 5th percentile, because I have mentioned here systolic blood pressure, 5th percentile. When we call it as an hypertensive patient, if it is less than 5th percentile. If you are struggling, if you're a person like me who doesn't like to memorize things, then at least remember this much for your exam, where you need to be aware of the adrenaline dose, where you need to be aware of the amiodarone dose, the energy for the synchronized shock, how much needs to be given, and the BP 5th percentile. That is 70 plus age into 2. I think in your blueprint, it might be mentioned as 80. Just change it. 70 plus age into 2 is the right one. Okay, this is the 5th percentile. Mean blood pressure, if you are checking, mean blood pressure. Okay, what should be the normal blood pressure for that individual? Then it becomes 80 plus age into 2. Okay, 70, what is 1? What do you need to remember? This is the 5th percentile. Below this calculated blood pressure, then you call it as an hypotension. Last topic here is foreign body obstruction. Okay, whenever you're suspecting a foreign body obstruction, do not be heroic. It might be outside the hospital. Always call for the help. Then start assessing the patient. Is the cough effective? That means he's having a good cough. Okay. If you're having a good cough, encourage him to cough. Do not take the patient. Encourage him, cough more, cough more. It will come out, cough more, and closely monitor the patient. No, the cough is not effective. If you're not already called for the help and the ambulance, call for the help and ambulance immediately. If the child is, if the cough is ineffective, how do you know cough is ineffective? He's not coughing. He's doing not like this. That is an effective cough. or the patient, or they have mentioned in the stem of the question, we cry. That also you need to consider as an cough as an ineffective. If the cough is ineffective, you need to see whether the patient is conscious or unconscious. If the patient is conscious, then what next to be done? It depends on whether it's an infant or a child. If it's an infant, what you're doing is you're giving 5 back blows as shown in this picture, followed by 5 chest thrust. What is the difference? You're going more deeper here. Chest thrusts are given more deeper here. What do you need to be aware of? Usually, how deep you go in an cardiac arrest in a pediatric age group? We go approximately 1/3 of the AP diameter in a cardiac arrest. Okay, 1/3 of the AP diameter in a pediatric age group, we go at that depth. More than that depth, almost half of that, what you'll be going, almost half of the depth, what you'll be going in an foreign body, because you want to increase the intrathoracic pressure so that the foreign body is expelled out. So after doing 5 thrust, always look in the oral cavity. If you can directly visualize, remove it, or look the surroundings if the foreign body has come out. Same thing holds good here. After giving an 5 chest thrust, you look something has come out in the surroundings, or you look the oral cavity and see if you can visualize the foreign body, you will remove it. You keep on continuing till the patient becomes unconscious, or the child is unconscious at the beginning itself. Then you start the pediatric BLS. Pediatric BLS means first 5 rescue breaths, reassess. That means look in the oral cavity and surroundings. It has come out, not come out, then you start the chest compression at the ratio of 15:2. What if the child is not an infant? It's a child. Okay, it's not an infant, it's a child. That means more than 1 year. If it's a more than 1 year, we give 5 back blows as you're seeing here, and we do something known as abdominal thrust. This is known as Heimlich's maneuver. Abdominal thrust you are giving it. In an adult, you can stand like this back and you can give it easy. In a pediatric age group, you might have to kneel down to their height and give it. Okay, so how do you give an abdominal thrust? In an abdominal thrust, you are going backwards and upwards in this direction. It is backwards and upwards. It is also known as Heimlich's maneuver. Okay, remember, backwards and upwards, it's also known as Heimlich's maneuver. In adults, it's the same thing. Check for the, always call for the help. In adults also, do not forget. If it's a mild obstruction, encourage for them cough. Continue close observation. If it's a severe obstruction, is the patient, sorry, if this is severe, suggested by an ineffective cough, if the patient is unconscious, start the CPR. That is nothing but adult BLS where chest compression starts first. Here is the pediatric BLS where rescue breath comes first. No, the patient is conscious. Then you give 5 back blows followed by 5 abdominal thrust. Same thing, there is no actual change. The only change is for the infant, where instead of abdominal thrust, we give just chest thrust. Okay, instead of abdominal thrust, chest thrust are been given here. During resuscitation, that means the patient is unconscious, you started the CPR. What needs to be done? Okay, if you are skilled enough, you can do a laryngoscope and try to visualize the foreign body and remove it during the CPR. Always consider doing an early intubation. If a cardiac arrest is due to an tracheobronchial foreign body, intubation is still preferred. Okay, still preferred is the still best option. What they do, what they want you to do, if the foreign body is here with the ET tube, they want you to push this foreign body to one of the main bronchus and ventilate one of the lungs. That's what they want you to do it. One lung ventilation, they want you to do it. Sometimes intubation might not be helpful. At that point of time, front of neck access will be required. That is important. At that point of time, front of neck access will be required. What is this X-ray suggestive of? This X-ray is suggestive of a foreign body inhalation. So what has happened? The foreign body has been sucked in. So it gets sucked in during what? Inspiration. It gets sucked in during inspiration. So it went in and it got tightly sealed in the inspiration. So what happens? Air which went in during the inspiration is trapped here. As the air is trapped here, what is happening? It looks more black in color compared to the opposite lung. So the foreign body is here. It appears more black in color for this reason. The patient is not in cardiac arrest, not having just having a breathing difficulty. It has gone into the main bronchus. At this point of time, what do you do? He's just coughing, doesn't have anything. You got a chest X-ray done. What you do at this point of time? It is not in the trachea. What you do? It is here somewhere. At this point of time, what you need to do is you need to involve the chest physician for a bronchoscopy. Bronchoscopy is both diagnostic and therapeutic, so you're using an bronchoscopy at this point of time. That ends the chapter. Anyone has any doubts, you can ask me now.